Good afternoon, dear colleagues, and I would like to introduce our first speaker, Professor Gil Wernovsky from George Washington School of Medicine and Health Science. Please.
Thank you. Thank you. My brother from Ukraine. I appreciate you. I think we probably were in the same country at one point, depending on when you drew the map. It was probably 1405. I'm going to thank you all for being here today. I'm going to try to sum up a lot of work that's been done in the last 3 decades in just about 30 minutes. So I'll do the best I can. And like I did the other day, I'm going to do this through some personal experiences and a little bit of a review of the literature. I have no financial disclosures or off-label uses of medications, but I do get to see pediatric patients in the outpatient department, and it is one of the thrills of my career after taking care of them in the intensive care unit. It's a privilege that a lot of the perfusionists don't have the opportunity to get, and I hope I can share with you today what happens to many of these kids over the long run. To remind you, again, the BTT shunt in the 40s, bypass starting in adults in the 50s, although it was atrial septal defect, then echocardiography prostaglandin in the 70s, which opened up that window for neonatal heart surgery. So the Norwood arterial switch, et cetera, in the 80s. And I just was very nice to see Jerry Getz, a perfusionist that I worked with in this time, and Bettina, who's the 2 perfusionists I work with as a young trainee. And here you're going to get a chance to see many of the results of the patients that you helped treat. It wasn't until we were able to do that and these kids got into school. So it's taken about 5 decades from the time we first could help some of these kids to learn sort of how they were doing. So why am I even here? I'm a pediatric cardiac intensivist at a perfusion symposium. I'm in a unique position because I'm a pediatric cardiologist. I work in the ICU. As we say, we know how the blood goes around after a stenting operation or whatever. We do know that a good operation doesn't fix everything, and I'm going to get back to that. And we started to realize in the late 80s, early 90s that some of the kids were having trouble meeting their developmental milestones. I had a medical school professor that said, half of what I'm teaching you is wrong, and the problem is I don't know what half it is. And I really believe that we have to keep that stuff in mind. The things that we believe are truth that you've learned at this meeting will turn out to be ways that we could do it better. But when I started my 2nd year fellowship in Boston, here were some of the truths. And this came from Dr. Aldo Castaneda. A good operation fixes everything. If you fix the heart, everything is going to be okay. The majority of the babies were normal except for their heart. Seizures were not a bad prognostic sign. In fact, Dr. Norwood used to call them baby twitches. Prolonged neuromuscular blockade, high-dose narcotic anesthesia was necessary after surgery, and that some of the survivors had developmental delay, and we and families and unfortunately lawyers immediately jumped to, it must be the surgery. So let's talk a little bit about what we know about the effects of circulatory support on the brain of infants and children. And again, this could be a whole symposium, and I'm just going to summarize one study that I was involved in that started at Children's Hospital in Boston in 1987, was the pilot study, where we did a randomized, it's called the Boston Circulatory Arrest Study, and we randomized patients after parental consent to either a period of circulatory arrest. If I start on the left, there was surface cooling, core cooling on pump to about 18 degrees, and then either circulatory arrest or low flow bypass during the period of intracardiac repair and some of the arterial switch, rewarmed and brought off bypass. And I'm going to show you 30 years of data where the only difference in their intraoperative management was the 1 hour down there at the bottom of profound hypothermia. So they're 30 years old, 1 hour difference in the OR. So, and I got the consents. It was an interesting consent process with the parents when I said, well, we're either going to keep the pump on or we're going to turn the pump off, and trying to get them to sign a form that they would go 50-50. It was an interesting process to have them agree to that we had equipoise. We didn't know the way it was going to go. We started out with 181 patients, 180 consented, 171 were randomized, and 168 survived. And this was during a period from 88 through 1991. This was the time course of the study, and this was funded by the National Institutes of Health. I'm not going to go through all the papers, obviously, we're not going to, but I am going to summarize the key points of this project. The first, at 8 years of age, it was found that neurodevelopmental outcomes were generally not adversely affected by circulatory arrest unless it exceeded a threshold of 41 minutes. Now remember, this was the way we took care of these kids in 1988. Very, very different than the way we're taking care of kids now, both in the OR and in the intensive care unit. So how strong was this effect? Well, there was this p-value, and we all love p-values, and a p of 0.04. But I do want to show you the scatter plot. If you can convince me that there's a significant difference between that IQ group and this IQ group based on the duration of circulatory arrest, I'd like to know how. But statistically, it made a difference. But we did start to see these inflection points at about 41 minutes for the probability of clinical seizures, not so much with EEG seizures or the appearance of any activity on the EEG. This is now IQ measured at age 8. And again, you start to see a little bit of a fall in IQ at about 41 minutes, achievement scores, and definitely some differences with fine motor scores and speech scores in young children. So I don't know how many of you have heard that term, circulatory arrest. 40 minutes is sort of the upper limit, and people have done many things to try to either get around that or obviously very complicated things to avoid circulatory arrest altogether. And so there's our 41. That seems to be this magic number, certainly in many in the centers I have. I was struck last night. I don't know how many of you heard Chris last night speaking about being underwater. And you know how long he was underwater with total circulation? It was 41 minutes. He showed that slide last night, and I was like, oh my gosh, that's sort of, I got a little crazy. All right, so you guys work with these fancy machines. And you work in the OR, high intensity, a lot of science with pH stat and alpha stat. How do we assess the kids? We ask them to look at pictures. I don't know what the predictive validity of this. This is called the Fagan test of infant intelligence. The person sits in the back and sees how long the child likes to look at the novel figure versus the new figure. That's what it looks like there. We time that. Turns out that is related to the incidence of ADHD as kids get older. We see how they play with blocks. What do we ask toddlers to do when they go to school? Sit still, pay attention, learn an alphabet, follow directions, and play well with others. These are the key things that are the important outcomes for second graders. Very different from what we saw when they were enrolled and we were taking care of them in the intensive care unit. Speech and language is a pretty complex thing, and what we see with many kids is that their receptive language, they understand the words coming to them, is normal, but their expressive language, getting the words out, can be problematic for some kids. What else do we ask second graders to do? Well, we talked about this, paying attention, learning letters and numbers, but handwriting is sort of the next part of fine motor control. I don't know what that says. That was one of the kids in our trial. But I got this letter from a kid named Chris, and I'll translate that for you. Dear Dr. Wernovsky, you're a good doctor and all, but can I go on roller coasters at Disney World on May 25th, which is 8 days from here? I hope I see you soon, from Chris. And I intubated this baby, and I took care of this baby as a little one. And it's, to get that kind of question, he just wants to know if he can go. I let him go on roller coasters, by the way, it's fine. And how do we measure this fine motor stuff? Well, when they get to about second grade, they can do these mazes, as you can see here. We can measure time on a grooved pegboard. And I know you don't get a chance to see many of these tests, but this is called the Ray-Osterith complex figure. We put this figure down in front of a child, usually an 8 or 9-year-old, and ask them to draw that figure with various colored pens. Later on, 5 minutes into the exam, we ask them to draw it from memory, which I doubt many of us could do if we took this away. And some of the kids did this really well. As you can see here, they got most of the pieces here. I think this kid just wanted to draw a duck. This kid just wanted to draw a parrot. This was the worst that we had. 8 years after an arterial switch operation, the pieces were all disjointed. How do kids do with that? Well, it turns out that the better you do on that test, it's actually got pretty good predictive validity on how you're going to do in middle school and high school. Another test we got to do is called the bears and the kite, where we'll show the kids 3 pictures. They'll see the bears, they get the kite, and then it gets stuck in a tree, and one of the bear goes up there, and unfortunately the bear falls and gets hurt. I mean, this is cruel. I have to think to do that to a 2nd grader. But they're then there to tell us what the story was. Expressive language delay was common. The stories tended to be more simple and disjointed. And as a group, not all of them by any means, but as a group, there was less ability to use abstract thinking. And again, we asked them to write the story out. And I think this is a bear was flying a kite, and then I got lost with what it was. When Amanda Schillingford was working with us at Children's in Philadelphia, she used a different cohort. This was the allopurinol neuroprotective trial that we did at CHOP. I think Jerry was involved with that one, where we looked using a standardized scale looking for attention deficit and hyperactivity disorder. And at this particular time found that somewhere between 16 and 26% of kids on various scales, depending on who was filling out the scales, would qualify for ADHD treatment. And this is a pretty typical graph in everything that's been published, which is half of the kids tend to be normal in every respect. And they've been through a lot. And then there's additional help in about 1/3. They may get an IEP, which in our country is just additional help in school. And then maybe 10% may have significant problems. So we've noticed at this point, now we're into the 90s, early 2000s, an increased incidence of speech and language problems and all the things that you can see on this slide. But then let's superimpose the problem of adolescence. I've been told adolescence is a disease in and of itself. It's short-lived, they outgrow it, but you're superimposing this. And remember that all of these kids that I'm talking about from the early trials, they didn't have the internet yet. So they thought they were the only child in the world with an arterial switch operation or a Norwood. It's a deeply difficult time for those kids. I like to use this as a chance to show this picture of Richard Jonas and I over here on the left with these 2 twins that had arterial switch in the trial, and then we get a chance to see them as they grow up. But the teenagers really don't want any part of us. All they really care about is their friends. So what we don't know from the data we had up until now is not so much IQ and school performance, but the things that are important to teens. Can I drive a car? Can I play in the band? Can I learn a 2nd instrument? There's complex stuff that goes on in here. So let's take that circulatory arrest trial and bring them into the teenage years. And this was published about 13 years ago now. And again, it's just been wonderful to see this cohort go through. This is, again, the same cohort we talked about before, and our follow-up team was just incredible to get 140 kids back 16 years later after a clinical trial is numbers that are just about unheard of. They did a really good time, and we looked at all of these things that are important from a school perspective, and we did an MRI. Now, from a cardiac perspective, and this is where we had been 10 years earlier, they were doing great. Only 4 were on any cardiac medications. They didn't have any limitations. 7 had a couple of catheterizations. Reoperation was very rare. And the arterial switch has been an amazing success for the disease of transposition of the great arteries, without question. However, what was starting to be learned now, around 2000, 2005, was you're 4 times more likely to be on psychotropic medications for ADHD or depression or things along those lines if you were operated on 1988 to 1992 than cardiac medications. And I always need to put that in. 2/3 of this group had some special help, and you can see all the things down here at the bottom. The kids that we're testing now are clearly doing better. We've been sharing best practices across institutions. And the internet has made some incredible support groups for families, and we're getting families involved in that stuff early on. So these are the percent of patients with abnormal scores. I want to show you one last thing that we're learning from this study, which is deficits in social cognition. That's the theory of mind, the ability to read other people when you walk into a room. And some of the kids were having difficulty with this. The way that gets tested is with this really cool test called reading the mind in the eyes, and you show this picture to people, and you ask them which of those four is that picture. There's not a right or wrong answer, but they did normalize this to a bunch of college students at Yale. So take that for what it's worth. But that's supposed to be serious, and this one here is supposed to be distrustful. And if you looked at the number so-called correct across the university scales, you would see that distribution, and our cohort from the circulatory arrest trial was way skewed over to the left. So we've seen behavioral difficulties, social isolation, autism spectrum disorder at a higher number than the regular population. But remember, half are normal in every respect that we test these kids with. So we did a lot of studies at 16 years, 1 year, 4 year, 8 years. There was some differences. Circulatory arrest was worse. Low flow bypass was worse in this area, but pretty much everything was similar. And again, at 16 years, that hour in the OR, that time that we spend so much attention to about circulatory arrest and alpha-stat and pH-stat and all that stuff, it makes a difference, absolutely, but it is very different than the other things that are the stressors for these kids and their parents. And so I think it's clear that the conclusions drawn about the long-term development of children based on those one-year evaluations when circulatory arrest got pretty much wiped out of our practice. I don't know how many of you use it, but I think if you did this study now, I would suspect we wouldn't see any difference. And we don't use that technique anymore. I will say this is what I thought I was getting funded for back in 1998 and 1988, but this was just presented at the American Heart Association, the 30-year follow-up. So 88 of those adults are still being followed up, as you can see here. And again, this was in an early era of cardiac surgery, but about twice as many of the cohort have mood disorders or anxiety disorders or substance use disorders. And that's real common in the adult congenital population, the ACHD. There's a lot of reckless behavior because they think, well, I'm not going to live very long. I'm just going to do all this stuff. And now that we learn this, I think we have an opportunity to help them early on. Okay, so this 30-year study now that I've been fortunate enough to be in has cost us, I think we've learned a lot, but it has cost $24.5 million US based on $2025. And as I said before, well, there's a couple of corollary wins. The forms that we used in 1988 have been used for a randomized trial of milrinone, have been used for the single ventricle reconstruction trial. We learned that we could collaborate across centers. We learned that we could do randomized trials in surgery and perfusion. But I'm always skeptical about what we're measuring over here on the left and all the things that are done in the operating room, and we're testing that with the types of tests that you can see here. It's the best we got, and I think we're going to learn more as we go forward. What's the predictive validity of all of that? We have not looked yet at all of the right brain stuff, which I think is our next area of looking at. Are there genetic polymorphisms that may adjust? Remember, we've only studied transposition in detail, and there are differences between lesions. What about within lesions? Are there modifying factors? I had to show this. I got this from the National Enquirer. There's these 10 song titles in the bottom left, and one of them is "You're the Reason Our Kids Are So Ugly." You can find all sorts of stuff like that. So here's where I work. I work in the intensive care unit. Effects of CHD in the fetus, then some things happen, then the outpatient findings, and then some stuff happens. And these are the areas that we are working on now. So the summary of all of this is that, and we're doing a lot of research now, it's really quite interesting. And the reason we could do all this research is the kids survive. We have kids now that we can take care of, that we can learn these things for, and it's fantastic. So here's the take home from what we've learned. About 50% have been diagnosed, again, operated on in the 20, 30 years ago with ADHD, 40% with problems in social cognition, executive function, alexithymia, a third with motor problems, a third with speech problems, about 20% with mood disorders, cognitive disability, about 10% of autism spectrum disorder. And I do want to mention about 30% incidence of PTSD and parental mental health challenges going through this at a time when we didn't know how important it was to support the family, not just the kids. That's changed, thankfully. And many programs now are working on family mental health and getting families into the appropriate amount of counseling that helps them. Because the better the folks are doing, the better the kid is doing. The most consistent matter that affects this is the duration of the ICU stay. This again is from the same trial, the 8-year data. The longer one stayed in the unit, the lower the full-scale IQ and verbal IQ got. And what does that mean? That association was very strong, but for every day in the ICU, there was a reduction over the median. There was a reduction of 1 IQ point. That's pretty important. Again, in transposition in a different, and maybe very different in some other areas, but why is that? And that's, when the ICU stays between 3 and 11 days, that's pretty important. So CICU is a cumulative exposure to their hemodynamics, pain and its treatment, anesthetics, chemicals, noise. I'm not going to go into this. These are the results of all sorts of studies that are going on right now. As I mentioned, there's an increased degree of PTSD, and the longer the ICU time, the more likely the PTSD. So I'm going to put this in some perspective. So for those of you who work in the OR, surgeons and perfusionists, anesthesiologists, let's say you're doing a Norwood operation, there's your 2 hours, I'm making up 2 hours, 2 hours on pump. You're really concentrating on that circ arrest time or that regional cerebral perfusion. And those 80 minutes are extremely important. If you're the anesthetist, you've got a longer period of time. So now you're looking at the total OR time. From my perspective as a cardiac intensivist, that time in the OR is just a sliver compared to the risk that these babies are under in the ICU. This is the time in the hospital. The time in the OR, and this is just your first year of life, is dwarfed by what happens outside of the hospital. So the relative contributions to long-term outcomes, what goes on in the OR in most studies accounts for about 3 to 5% of the variance in scores. What goes on with family mental health is about 29%. So our focus now is going to be on supporting families and working in the intensive care unit to try to make this better. Let me just jump ahead here. I don't want to go over in our time. I learned a lot from doing this with the National Pediatric Cardiology Quality Improvement Collaborative of the trauma that families go through in terms of watching in the ICU, the trauma of handing them over to the unit. Or to the OR. I can't imagine what that's like. Sitting in the ICU, seeing what happens around you in the ICU, if there's vicarious trauma in the bed next to you, let alone what goes on at home. This is one of my favorite memes. I know families that haven't gone on dates for 3 years after their baby went home because they don't really know who's going to babysit for them. Let me see if this audio. So,
Dr. Valentino, to the OR, please. Dr. Valentino, to the OR, please. Dr. Valentino, to the OR, please.
So you can imagine what the trauma is walking back into the hospital for many families when they hear this coming back in for a Glenn or whatever. I get traumatized hearing this sort of stuff. And this is real re-experiencing, and we're addressing this now. And I'm happy to say that that's the case. All right, I'm going to just skip ahead so I don't. Okay, so despite this rose-colored glasses that I have and the stacked deck against our patient, late death is uncommon, unplanned reoperations are uncommon, procedures are generally well tolerated, and the group scores are lower than the population means, but the majority of these children, despite everything they've been through, are doing really well from a neurodevelopmental perspective. As researchers, we look at it from what are the risk factors. I'm starting now to study we have rock stars. 2 days ago, I showed a couple of rock stars, one who's a pediatric cardiologist, one who jumps out of planes. What makes those people special? Why don't we study that group? And that's where we're headed to now. I think I'm down to 5 minutes. I started a little late. So I want to share one clinic visit with you, if you don't mind. Again, teenagers, they don't like to come to see me. I don't blame them. And I was seeing this young man, his name was Jonathan, and he had total anomalous pulmonary venous return. And I had written this paper, this is about 2007, I'd written this paper in 2004, where we said at the bottom line, you could see there, neuropsychologic evaluation of patients with total veins is warranted to identify neurocognitive defects. And the mom excused her son, and she reached into her bag and she held up this paper and waved it in my face. And she said, "You've known about this for 4 years and you haven't told me. And what are you doing about it?" And, you know, she was absolutely right. So we're in an era now where we can't just describe findings. We have to start to make this work better. I think what we do is the best team sport. It starts in the OR. When I look at what happens with the circulator and the anesthesiologist and the surgeon and the perfugist, I'm always just blown away by the teamwork that goes in there. Anytime I say the word team, I have to bring up the Philadelphia Eagles. You can't be great without the greatness of others. This is the Cardiac Neurodevelopmental Outcome Collaborative Leadership Group. We meet every year, and we started because of these findings. And I guarantee you the little babies that are home now are going to be doing much better than the group that I described earlier on. Richard, you wanted me to say a couple of words about Jim. Is that okay? Just a couple. I'm going to just digress for just a second and talk about someone who is near and dear to my heart, and many of you may know. Is anybody here from either Cincinnati or Milwaukee? They may be online. They're online, yeah. Okay, so we're approaching the 3-year anniversary of the passing of Jim Tweddle. Jim, cardiac surgeon, started Children's in Milwaukee and then was the chief at Children's in Cincinnati, and unfortunately died after a battle with brain cancer 3 years ago. He was the quadruple threat. He was not only clinical and teaching and research, but his ability to be humble and be academically honest and be funny and to attract people around him was unique. He was a co-editor of our textbook that I'm glad he survived to its publishing in 2021. He was an amazing mentor and just loved taking care of kids. But what he loved more than those things, and he was amazing at that, was fishing in Sanibel. And when you told me, you know, it'd be good to talk with him, I contacted Susie, who's his wife, and I said, "Do you have any pictures of Dr. Tweddle in Sanibel?" And she sent me 30. But he loved this. He had 3 daughters. They were married on the beach of Sanibel, which is right up the road, and he would have had such a great time at this meeting. The one thing he liked also more than cardiac surgery is the banjo. And we have a band of pediatric cardiologist surgeons and whatnot called the Baby Blue Sound Collective. We were the Blue Baby Sound Collective, but the parent groups didn't like us to be the Blue Baby, so we were the Baby Blue Sound Collective. And he loved playing the banjo. He covered Post Malone on the banjo. I don't know if anybody else could do that. Here he is practicing with our group. He really got into it, you know. He just absolutely loved the banjo. I don't know if this is going to come through. Let's try. We could do an OR. We had an anesthesiologist, intensivist, surgeons, perfusionists on this stage. It was really terrific. And no matter how many times I asked him what's worse than a banjo, he would always say, "What, Gil?" And I would say, "2 banjos." And he would laugh every single time. So in Jim's honor, I do want to thank you very much. He was a team leader. He really exemplified what happens in your ORs. Since we're right down the road, I just wanted to give him that little tribute. And happy to answer any questions. Thanks very much for your time.
Dear Professor Wernovsky, thank you for your nice talk. It's really great. Any questions from the audience? Please.
Yeah, I mean, first of all, Gil, thank you for coming down to this this little meeting. You know, one of the greats of pediatric cardiac intensive care. So it really is an honour for us to have you here. I always look at your pie chart if you had it, and I've always had an argument with a surgeon for many years, saying, especially with these cyanotic patients, they spend all the time in the womb, and they're fairly cyanotic, and they get out of born, they get into intensive care, they get everywhere else, and they're still cyanotic. We're then given on bypass for a very small sliver of it, and apparently that is to blame for all the problems that then come afterwards. So it's nice to see that pie chart isn't quite accurate as they think it is. So
yeah, bad things can happen. There's no question. You guys sort of be sure that it doesn't. But when the case goes well, and the malpractice attorneys love me for this, what goes on down there with all these things that happen to kids are start in the womb, happen in the OR, a tiny bit, happen in the ICU, a bunch, and then follow up at home.
And I think we, as sort of, particularly in pediatrics, it's going to the idea of actually we need to get away from did they live or did they die, and more towards did they have a quality of life.
Mm-hmm.
But that's who knows.
Hi, Luke Pui. Thank you so much for this wonderful presentation. I used to do a little bit of pediatric bypass like 20 years ago, I think. And at that time in Europe, they were thinking about, they were also looking at this. And I remember that they were starting to look at what was the predisposition for these children to already have cerebral lesions, or because of their cardiac lesions. Like, is there anything that is like?
Yeah, it's a great question. And as I said, this could have been a whole meeting, but the effects of fetal congenital heart disease are real. And if you look at an MRI of a term baby, the brain has the maturity of a 35-week brain. So the brains are immature at birth. So we start with that. And then the babies that have the lowest oxygen delivery in the fetus, and this is by new MRI data, are babies with transposition. So the group that we have studied the most are probably the group most at risk in the womb. Now, the good part of that is they generally have one operation and then they're not hypoxemic anymore. So there's so many additive factors, they're cumulative and they're sequential, that when we try to study one of them, it's impossible to tell what the contribution is. But we know that what goes on in the fetus is a significant part of that. That answer your question? Okay.
One more question.
Very quickly, do you think social media nowadays in the big connected world in which we live in would alter in a positive way or a negative way the development of these kids?
Yes. Both, I think.
Thanks.
No, seriously, I think it's both. I think that the connectivity with others, with their problems, going to camps, things like that, are incredibly resilient. And then the constant scrolling and social isolation obviously can take the exact opposite effect. So we'll see. We'll see.
Any questions from the chat? Not sure. Okay.
There's one back there.
Sorry, Erin Montague from Children's in DC. I was going to kind of touch on what you just asked when I said this. I am a member of several cardiac chat groups on Facebook, one being Ross Procedures. And I cannot tell you how many times I have seen parents come on and say, I'm thinking about getting this for my kid. I'm going to see a doctor. What should I ask them? I don't know what to ask them. Can you give me questions? And I think for us as a community, we're people that could actually help them with those things. But the only people that generally join those chat groups are people who have had surgery or who are going to have surgery, which is great. But it would also be nice to have more professionals in those chat groups who can give them real answers without having the experience of, well, I'm a parent and it was just horrible. Or I'm a parent and everything was so easy and I didn't have any problem. You know, that doesn't really help. But what does help is you should, you know, ask what your qualifications of your surgeon are, or what route they're planning to do, or if they can't do a Ross procedure, what are they going to do and what are your options? And those are things that the parents don't actually know to ask. They're just going in and saying, well, whatever you say, I'm going to do. And while, yes, the surgeons are the professionals and they probably do know the most, it would help the parents mentally, I think, and the patients, if going in, they knew the right questions to ask so that they felt more comfortable. Because as you said, this is a huge traumatic event and PTSD is real.
Thanks, Aaron.
So, any questions?
I wanted to give a shout out to Bettina Cuneo, who's a perfusionist I worked with in that study. So all of those results you were responsible for. And that's because they're alive.
So, the last questions I have, what is the role of perfusionists in success of pediatric cardiac surgery?
You're asking me that, okay. I remember Dr. Castaneda telling me that no role is more important than any other, right? It's a big circle with everybody holding hands, so that if there's a hole with the surgeon, everybody says that, but it's the same thing in the intensivist and whatnot. It's being part of the team and being humble, and everybody knows their job and does their job. That would be the way I'd look at it. I'm glad you didn't ask me the role of the cardiac intensivist.
Okay.
Thank you all very much.
Thank you so much.